quantify brain metabolism so you can get a better idea of what neurodegenerative disease a patient may have. Because if you're just looking at CT and MR, you'll see patterns of atrophy that are non-specific, but a PET scan is a much more sensitive and specific way to kind of diagnose degenerative dementia. So this is kind of the list of like the topics I'll be talking about today. So I'm going to go through some like masses. There's several masses that showed up on your prior in-service exam, which I'll kind of go through. Intracranial hemorrhage. We'll talk about hydrocephalus and NPH. I'm going to go over a few different kinds of infections. For toxic metabolic, I have Wernicke and Markia-Fava Bignami, but I also have Wilson's disease in there as well. Actually, this is over here, and I'll talk about other things like Cadicil in terms of like vascular causes for dementia. So let's just start quickly with our first case. The first couple things I'll be talking about are going to be some reversible causes of dementia, or cognitive decline, more specifically. So first case, it's a middle-aged to older female with like a subacute history of memory difficulties, right-sided visual loss, and like importantly, she doesn't have headaches. So SIC. Take a look at this case. This is from your prior RIDE exam a year or two ago. Just tell me what you see on here and what's abnormal. If he's there. Let's see. Sadaf, can you hear me?
Yes.
Okay. So take a look at this case and tell me what you see on here. What's abnormal?
So it seems like some, I'm sorry, I need to mute it. So leave this. So I feel like there in the first picture here is the T1 sequence. We see isodance things in the posterior horn of the ventricles, and then the next image looks like to be T1 post, which I see hyper, like it seems to be enhancing things going on over there. And the third image is DWI, something still enhancing. And the last image looks like to be ADC, that kind of correlate with the DWI that we saw. Okay. So there is a enhancing lesion.
So your localization is it's a little bit off. So you said ventricles.
Yeah.
This is a different area. So like what white matter tract is in the midline? What white matter commissure is in the midline, the biggest one?
Cingulate gyrus is in midline.
Corpus callosum. Corpus callosum.
It's corpus callosum, yeah. That area.
So what part of the corpus callosum is this?
A splenium.
Right, so there's an enhancing mass in the splenium of the corpus callosum kind of crossing it with restricted diffusion. Can you give me a narrow differential of a couple things that a couple masses or mass-like lesions that can involve the corpus callosum?
No, I don't know any specific mass that could affect the corpus callosum.
So there's a classic differential of like maybe three things that can for mass-like lesions or masses or tumors that can go in the corpus callosum. Glioma, including GBM, is going to be a big one. Lymphoma is going to be another one, and then tumefactive demyelinating lesions are going to be another one. Once in a while, if you have a parafalcity meningioma, it can also like kind of grow into and squash the corpus callosum. But the big ones to think about are going to be GBM, lymphoma, and then tumefactive demyelination. And if you look on here, this actually restricts. Do you know what kind of tumors restrict?
So lymphoma and glioblastoma should be seen in the DWI.
So densely cellular tumors in general restrict. Any kind of tumor, even if it's GBM or what have you, can restrict. The classic ones are going to be lymphoma, meningiomas, and medulloblastomas. A GBM can restrict if it has densely cellular areas, but these are the more classic ones that they talk about. Given the imaging appearance in the corpus callosum, like and narrowing into these things with a restriction, the best answer here is going to be lymphoma. So this is another case from your in-service either a year or two ago. There's this lesion kind of in the right frontal lobe that kind of like goes into to a mild degree into the genu of the corpus callosum. This is also a glioma. I think this was anaplastic based on like what the answer choices were on the exam. This is a really heterogeneously enhancing mass. For a primary tumor, this would be a very good appearance because of the fact there's so much enhancement and heterogeneity for a GBM. Let's see, who else can I call on here? Jihan Park?
Yes, hello, Dr. Velayudun. Hello, can you hear me? Hello?
Can you hear me?
Yes.
Okay, so take a look at this case. They showed this on like the past 2 RIDE exams. So if you look at this case, look at the posterior fossa, there's a cystic lesion with a mural nodule in like the cerebellar hemisphere. The most common cerebellar mass in like an adult is actually going to be a metastatic lesion. However, if you see a cystic lesion with a mural nodule that's a primary tumor, there's a different kind of like narrow differential for that. Do you know what adult tumor can give you this appearance?
I would think of hemangioblastoma, pilocytic astrocytoma, and pediatrics. Yeah.
Right. So cerebellar cyst with a mural nodule, this has been shown twice in the past couple of years. So the most common cerebellar mass in adults can be a brain met. However, if you see a cyst with a mural nodule and it's a primary tumor, for an adult, think of hemangioblastoma, which has a high association with von Hippel-Lindau. And if you see it in like a child, think of JPA. This is another example of kind of the same thing, a large cyst in the cerebellar hemisphere with a mural nodule that avidly enhances and is vascular. If it's in an adult, think of hemangioblastoma. If it's in a child, think of a pilocytic astrocytoma, which is like a WHO grade 2 tumor. This is another thing that was shown like recently. If you look at this case, there's an expansile intracellular mass with supracellular extension without a dural tail. To me, I mean, like this was listed as, I think, like someone thought this was a meningioma. Me personally, I don't see a normal pituitary. I don't see a dural tail, and it's kind of expansile and going upwards. To me, this is a better look for a macroadenoma. And again, the reason why is expansile, intracellular, growing upward. I don't see the normal pituitary, and I don't see a dural tail. If I see a separate pituitary gland and a dural tail, then I would think maybe meningioma, but I don't see that in this case. This is another like example from like one of your RIDE exam from the past 1 or 2 years. There's a mass that's kind of coming from the pituitary fossa. I don't see a normal pituitary. It's kind of expanding the cell and growing upward. So this is a macroadenoma. If you look at the other images here, there's hyperdensity on CT, some bright T1 signal before giving contrast. So this is an example of, I guess, apoplexy. And again, it's a macroadenoma because I don't see a normal pituitary gland and there's no dural tail. I just see an expansile intracellular mass growing upward. This is an example of a meningioma. It's this dural-based lesion in the posterior fossa growing to the cerebellar-pontine angle cistern. Because it's kind of flat, this is like what's called an on-plaque variant of like a meningioma. Jihan, if you saw like something similar, like an enhancing cerebellar-pontine angle mass, but it's growing into the IAC, what do you think of for that?
Vascular schwannoma would be or any other like glossopharyngeal schwannoma.
Right. I mean, if it's extraaxial and kind of growing along the 7th and 8th nerve complex, the best answer probably would be a vestibular schwannoma. If you saw a cyst in this location, what 2 things would you think about?
Epidermoid, dermoid tumor.
Yeah, epidermoid or arachnoid cyst. If
Yeah.
it restricted, which one would you think it's going to be?
Epidermoid.
Right. This is probably another example of what I think is going to be a meningioma. There's this midline extraaxial mass associated with the falx. I'm not sure what the exact answer is, but that's what I think this is probably going to be. And Jihan, what type of enhancement is this?
It follows cell size, so I would think it's leptomeningeal enhancement.
Right. I think this is an example. So I think this turned out to be carcinomatosis, but like big picture wise, this is not enhancing normally, and your differential is going to be, is it parenchymal, is it dural, or is it leptomeningeal? Because it's going into the cell side and kind of around the brainstem. This is leptomeningeal enhancement. The specific patient has carcinomatosis. And one more thing. So just hold on 1 second, actually. All right. This is just another like mass-like lesion that was on your test, I think last year or the year before. If you look on here, there's this kind of structure that follows CSF signal intensity on the T2-weighted sequence. It doesn't have a lot of internal architecture and there's mass effect. I know this is not encephalomalacia because as opposed to causing its vasodilatation, it's causing kind of like some mass effect on the ventricle. So I think the best answer for this question is going to be an arachnoid cyst. So those are a bunch of different mass lesions that I saw in like your prior in-services for the past 2 years. So in terms of like getting back to the topic of the lecture for masses and people that have cognitive decline, I mean, it's a potentially reversible cause of cognitive decline. I would think about, it's an unlikely cause of cognitive decline, but I would think about it if you have someone that has atypical symptoms, if they do have a headache, if they have more rapid or subacute decline, and if they have a focal neurologic deficit associated with their cognitive decline. So those are just some masses just to talk about the topic for your in-service. Let's see. Trying to see who else I can call on here. Theodora? Let's see. Zhang Lan, can you hear me?
Yes, Dr. V, I can hear you.
Okay. So take a look at this case, and like it's pretty basic, but they've shown hemorrhages on your in-service in the past. So just tell me what you see on here.
So this is CT without
Okay.
CT without contrast. You see on the left supratentorium, there's half hypodensity, half hyperdensity. So I think what happened is probably this patient has chronic subdural, acute on chronic subdural.
Right. How do you know it's a subdural? Just tell me like 1 or 2 rules how you know.
The shape, it's more like a lens shape. Convex, I'm sorry. And also the, how do I know?
I mean, you pretty much said the most important stuff. So if it crosses sutures, epidurals don't cross sutures unless maybe rarely if you have a fracture that crosses a suture that it can do that. But classically, epidurals don't cross sutures. Subdurals do cross sutures and they tend to be more crescentic shaped. When they get to the midline, subdural collections, whether it's a hemorrhage or an empyema, will either stop or they'll go along the falx or the tentorium. So this is an example of a subacute, not subacute, an acute on chronic subdural hematoma because you see layering. There's a hypodense chronic component plus newer blood over here. This is either blood or like a membrane. In addition to the hemorrhage, like other positive lines that are pertinent here are going to be that there's mass effect. If you look on here, there's rightward midline shift, compression of the ventricular system, and also probably some subfalcine herniation. So is it epidural or subdural? It's subdural for the reasons that we talked about. So in terms of aging hemorrhage, acute blood is always going to be hyperdense on a CT scan. And then when you image them after a couple of weeks, it loses 1 or 2 Hounsfield units per day, and it becomes more isodense like you're seeing over here. I know there's a collection here because the brain cortex is supposed to go out to the inner table. Over here, the cortex is kind of stopping over here, and there's something extra on like the left side. And if you wait a few more weeks, it'll become very hypodense on CT. So this is a chronic appearing subdural. If you look at this case, it's different because there's hyperdense material on the bottom. This is a chronic subdural with more acute hemorrhage within it. This is a companion case from your prior in-service. So if you look at this, there's this lentiform kind of hyperdense collection over here. This is epidural, an epidural hematoma because it kind of like stops at the suture over here, the coronal suture. All right. And I saw them showing a few different, like on MR imaging, a few different types of like parenchymal extraaxial hemorrhages. If you look at this case over here, this is obviously going to be a subdural collection because it kind of crosses the sutures and then stops at the midline. Same thing over here. Dr. Zhang, how would you age this? Like, what do you think? It's very bright on T1. So what age do you think this is?
So, I mean, there's a mnemonics about this age on the MRI. So basically, so let's say on the T1 is bright. So T1 is bright. Well, do you have a T2?
This is actually a flare, which is kind of like a T2.
Okay, so bright on the T1, bright on the T2, so that'll be BB, so that'll be somewhat subacute, chronic subacute.
Right.
So that'll be 7 days to 14 days.
Yeah. So if it's bright on T1, methemoglobin is the one blood part that specifically is bright on T1. It starts becoming bright on T1 during the subacute phase when you have methemoglobin. So this is kind of a lot, but I think like whatever memory that you use is fine. Dr. Linden has a graph. There's a mnemonic that someone told me like 20 years ago that I still remember is like, I believe itty bitty baby daddy. But like it's just a way to remember kind of like how this stuff evolves. If I had to pick two things from this like chart to remember, subacute blood with methemoglobin, that's when it's bright on T1. And the only time blood is bright on T2 is when it's hyperacute, like the first day, the first few hours. And then when it's late subacute, that's when it's bright on there. So if you look at this case, like it's very bright on T1, it has a lot of bright components on T2, so it's probably a late subacute hematoma. Big picture wise, again, bright on T1, that's methemoglobin, that's subacute blood. If you look at this case over here, just to kind of go quickly through this. So Dr. Zhang, just take this case too, just for like speed purposes. So there's a head CT and some GRE images over here. What is GRE good for, Dr. Zhang?
So GRE basically look at the bleeding, like a hemosiderin.
Yeah, it's good for blood and for calcium. Blood and calcium are going to be dark on there. What's a better sequence than GRE for looking for blood or calcium?
SWI.
Yeah, exactly. Perfect. So there's parenchymal hemorrhages in a trauma patient at the gray-wide junction in the corpus callosum and also in the brainstem. So what do you think this is?
Diffuse axonal injuries.
Right, exactly. So we talked about the distribution already. What sequences are here? This is gradient echo. SWI looks similar. It's a more sensitive sequence. This is an example of diffuse axonal injury, which is a shearing injury. I'm just going to go through this quickly. And your clues that like you're dealing with this are going to be like the if you see hemorrhages in specific locations. So gray-wide junction is like one common place. Grade 2, which is a little bit worse, is going to be when you have it in the corpus callosum and sometimes in the internal capsule. And then lastly, if you see it within in the brainstem, that's like the worst kind of DAI. So just if you see hemorrhage in those locations, that speaks for DAI. If you have a hemorrhage that's kind of like near a bony interface and mainly cortical, that's what a contusion looks like as opposed to DAI. Best imaging tools are going to be gradient echo or SWI to look for hemorrhagic DAI. But you can also see the edema from DAI and also like non-hemorrhagic DAI on flare and on diffusion-weighted sequences. Okay, this was a case from I think a year or two ago, showing that there's a T2, like this kind of like T1 hyperintense mass with lots of vasogenic edema surrounding it. And then like when they give contrast, you don't really see too much enhancement. This could be a parenchymal bleed, like which has like a differential for it. But if they have known malignancy, what malignancy is bright on T1, Dr. Zhang? There's a specific kind of malignancy that when you have Mets from that is often bright on T1, separate from hemorrhage. It's a kind of skin cancer.
Oh, the melanoma.
Exactly right. I'm not sure what the answer for this was. I mean, if this is a brain met, I mean, the T1 brightness could be from methemoglobin, or if they have known melanoma, that can also be bright on T1. Okay. More examples from your prior right exam. So if you look at the SWI on this case, there's bright signal kind of over here that's like kind of like cortical or like just the cortical. Plus there's hemosiderin deposition within the sulci over here. So this is probably an example of cerebral amyloid angiopathy. If you see hemorrhage, that's mainly like cortical or lobar, there's a different differential for it than for hypertension. So if it's an older patient, I would think of like maybe amyloid. Around 10% of people that have hypertension can also get kind of like just the cortical hemorrhages. If you have a sagittal sinus, like a dural venous sinus or cortical vein thrombosis, that can also give you a cortical or lobar hemorrhage. A vascular lesion can also give you that like an AVM or AV fistula or a cavernoma can also give you like a parenchymal hemorrhage too. Contusions and DII we talked about. And then lastly, like the last case, if you have a tumor, either primary or metastatic, and it bleeds, that can also give you a parenchymal bleed that's in the differential for for parenchymal hemorrhages. This specific case, because of the fact that it has a cortically based hemorrhage in the sulci, or what's called siderosis, this is a pretty good appearance for CAA actually. This is another example of like kind of the same thing from your prior right exam. This person has these kind of like these areas of hemosiderin deposition in the sulci, superficial siderosis. So I'm guessing this is probably a CAA case. These bright dots over here, these like kind of fluid filled spaces are Vercat-Robin spaces. Let's see, Srinivas.
Yes, Doctor.
Okay. So pretty basic case. Just tell me what you see on here and what's abnormal.
Yeah, it's a CT scan showing that enlarged ventricles with cognitive decline and falls. It is like typical dementia, incontinence, and gait ataxia. That is hydrocephalus.
Right. So there's two head CTs. Like there's a head CT with the images kind of like higher up involving like the lateral ventricles and kind of lower down at the level of like the third ventricle, like the midbrain. So you see marked enlargement of the ventricular system out of proportion to the size of the cell size. This is definitely going to be a case of hydrocephalus. So what structures are abnormal? The ventricles are huge, like we were saying. And what's the term for pathological large ventricles? That would be hydrocephalus. The big clue here is that the third ventricle is huge and the temporal horns are really, really huge also, and the sulci are kind of narrow. So I'm just going to kind of run through this quickly. I mean, like it's a type of communicating hydrocephalus, which people have different thoughts for what it arises from. It can be from prior hemorrhage or infection. And if people have chronic hypertension and decreased compliance with their ventricles, that can be also like a thought to be a cause for this, related to small vessel disease. I think clinically, like it starts off with like you're supposed to have a gait issue before you get the dementia. That could be a clue clinically about like that you're dealing with hydrocephalus as opposed to something else causing big ventricles. And let me just keep going on here. So like MR, this is like let's see. So MR, one thing that you might look for when a patient has hydrocephalus of any cause is going to be enlarged ventricles, and on the sagittal image, you might see thinning out of like the corpus callosum. If you look at the anterior third ventricle, it's supposed to be normally pretty pointy on a sagittal image. So this is like a normal appearing sagittal image. The third ventricle, the anterior part of it, it's supposed to have two pointy recesses above the chiasm and above the infundibulum. When you have hydrocephalus, your anterior third ventricle gets enlarged, and those spaces, instead of being pointy, they get kind of like widened obtuse like this. So this is the axial kind of correlate of that. The anterior third ventricle is really, really big in this case. And one thing you might see on like say like a FLAIR T2 edited image is when you have like hydrocephalus, you'll get kind of increased flow through your aqueduct and like your fourth ventricle. So that's another thing to look out for on T2 and FLAIR. If you're not sure that if the enlarged ventricles that you're seeing are going to be from hydrocephalus or just like atrophy, I mean, there's a couple different measurements that you could take. One thing that people talk about is this thing called the callosal angle. If you look at the angle between the lateral ventricles on a coronal image at the level of say like the posterior commissure by the pineal gland, if that angle is going to be acute, like less than 90 degrees, I don't have the other thing over here, but if the angle is really narrow, like less than 90 degrees in the sulci face of the vertex, that's a pretty good appearance for hydrocephalus. If you have wide sulci and a wide callosal angle, that's less likely to be NPH. There's something called an Evans index where they measure the maximal distance between like the frontal horns and the largest diameter of like the brain at the inner table of the skull. If the ratio is like going to be like more than like 0.3, that's supposed to favor hydrocephalus. I personally think the callosal angle and a face of the sulci and a big enlarged third ventricle and large temporal horns are a much better like way to kind of assess for hydrocephalus. People have published this, but I feel like it's a less useful rule. In terms of additional studies that you could do to confirm if you're dealing with like NPH, if the CAT scan and like the regular MRI don't really give you an answer, there's two other things that you could do. One thing is going to be a CSF flow study where you kind of check the stroke volume going through the cerebral aqueduct to see if it's elevated. So you can look quantitatively to see if there's a large flow, like a jet of like CSF going through it. And they also can make a graph just to show you what the quantification of the stroke volume is. If that's high, that favors NPH. And there's a nuclear medicine study that you could do also to see if there's retained agent within the ventricles. It's called an Indium DTPA study where you inject Indium DTPA using a lumbar puncture into the subarachnoid space. And if you image the patient after 24 hours and the agent is still within the ventricles, that favors NPH. And this is normal. Normally it should like kind of circulate out of the ventricles and go over the subarachnoid space like a trident. So this trident appearance is normal. If it's stuck in the ventricles after 24 hours, that's not normal. Just going to kind of go through this quickly. All right. I showed this case last time. I'm just going to show it again just to kind of reiterate like an important topic. So infections can also be a cause of cognitive decline. Let me see. Michelle Bobrow, can you hear me?
Yes.
Yes. So take a look at this case. So we talked about masses in the beginning of like, I went through some masses that are on like the in-service that are also like that I think important to know. We talked about bleeds and like which ones are going to be bright on like T1, subacute blood, that kind of thing in like different spaces. Now I'm going to talk about a couple different infections. So just take a look at the question stem and the images and tell me what you see.
So
Can't hear you.
sorry, I didn't hear the last thing you said.
I said I couldn't hear you.
Oh, okay. Yeah, I was going to describe the images, but I guess we have a description there. Since it's non-enhancing, I don't think it's CNS lymphoma.
Right.
Also, I wouldn't expect CNS lymphoma to be in that distribution, periventricular white matter.
So actually, that's one of the most common distributions of lymphoma is going to be periventricular, but it should typically enhance. The main thing you're seeing on here is a patient that has this is a young person that has brain atrophy that's cortical and also central with like large ventricles from like white matter volume loss. There's pretty symmetric looking deep and periventricular white matter abnormal signal, and there's no real enhancement there. So I think lymphoma, I mean, even though this stuff is in like the periventricular area, it's not enhancing. So I think lymphoma is not a good choice for this. PML, is that classically periventricular or more of a peripheral thing?
I'm gonna say more peripheral, but PML could be.
It classically involves subcortical U fibers, but it can be diffuse. And it causes like a type of demyelination. So it likes to go into the corpus callosum too, actually. And just like other kinds of demyelination, it likes to go to the posterior fossa as well. This process is pretty symmetric and mainly deep. It kind of spares the U fibers out here. So I think PML is not a good choice for this. Toxo typically causes multiple enhancing lesions. I think the best answer here is going to be HIV encephalopathy. So lymphoma, this is classically what it's going to look like. We had a case of this actually a couple of days ago at Kings County. But it'll give you a kind of enhancing mass. It's very classically going to be periventricular. It can be multifocal in immunocompetent patients. If you're immunocompromised, it's more likely to be kind of a single lesion. It more likely rim enhances if you're immunocompromised. And it's densely cellular. So I showed an example of this before. Because it's densely cellular, it'll often be bright on CT and it'll often restrict on DWI. And this is a lesion that's a tumor besides a glioma that likes to go into the corpus callosum as well, which this lesion is doing actually. So PML, like we just talked about, it likes to involve subcortical U fibers. It's multifocal. It can be diffuse, and it can go into the corpus callosum. One differentiating feature also, in addition to being peripheral and multifocal, is that it tends to be very, very dark on T1, which is a little bit different than what you might see in a lot of cases of HIV encephalopathy. So this is like another example of PML, kind of like multifocal involving subcortical U fibers, like you're seeing over here. This is an example of toxo, which causes multiple rim-enhancing lesions in the brain. In general, toxo tends to, in HIV positive patients, toxo tends to be multiple, like 90% of the time. HIV tends to be more like this solitary if you're immunocompromised. So I'm just going to go through this quickly. I mean, this is from direct infection of microglia of your brain with HIV. It has I mean, the higher your viral load, and if you actually have AIDS, like the worse it's going to be, obviously. And I've seen some cases where it looked reversible, where if the patient's like viral load went down, and they were treated, actually, the white matter abnormality got a little bit better, and it should not enhance. Let's see. Sergio?
Yes.
Okay. All right, we're still talking about infections. So take a look at this case, look at the stem, and look at what's abnormal. These are two different patients, and tell me what do you think is abnormal.
Hold on 1 second. Okay. The light?
So they're gonna talk to hello. So basically, I'm seeing diffusion restriction and the heterocaudate, a little bit like a hockey stick on the thalamus bilaterally, and on the right, I think that you can see some like ribotin in the most like in the occipital lobe bilaterally.
Yeah.
And yeah, I think it's this is a CJD. That's basically
right. Let's say I didn't tell you the history. Let's say I told you the patient coded. What do you think this would be then instead? The history, I think, is the most helpful thing here, that there's restricted diffusion involving deep gray and cortex in a different patient. It's subacute, they have cognitive decline, and they have myoclonus, and that's a pretty good like kind of history going along with these images for CJD. But let's say I told you they coded, what else could give you this appearance where you have gray matter involvement, deep gray, and like cortical that's symmetric?
Can be like a hypoxic encephalopathy.
Yeah, I mean, that's another thing to exactly. That's another thing to think about if you have kind of this pattern where it's like symmetric and involving gray matter structures, and then maybe something metabolic is another possibility for this. The history is, I think, the main feature that helps you differentiate what this is. So what structures are involved? What's your differential? So we just kind of talked about this. Basal ganglia, including the caudate heads, and to lesser degree the lentiform nuclei on both sides. The thalami, which is called the pulvinar sign, or what's called the hockey stick sign because of the shape. And the cortex is involved in both sides in this other patient, actually. So differential for this, I mean, like if you have a person that coded HIE can look like this. If it's a dementia patient with rapidly progressive dementia myoclonus, now think of CJD. I'm just going to kind of go through this quickly. I mean, there's different types, like 3 major types, sporadic, variant, and like the familial type. It's a pretty rare disease. Just going to go through this. There's just more examples of the same thing. The history is going to be the major thing because other things can cause restricted diffusion that'll give you ribboning like this. If it's a dementia patient and it's rapidly progressive with myoclonus, then I think of this disease specifically. This was a question under in-service. I'm not sure what the answer was, but this is one way that CJD might look with restricted diffusion and flare hyperintensity involving deep gray structures. If it's a dementia patient, this is a good look for CJD. This might be also. Another thing that can give you restricted diffusion in your thalami bilaterally would be if you have artery percheron infarcts, and if you have internal cerebral vein thrombosis, that can also give you infarcts here in the thalami. Let's see. I don't know how to read this, but apparently periodic spikes is a thing with CJD. All right, this is something that showed up on your in-service within the past 2 years. Let's see. Lisa Calva.
Hello?
Hey.
Hi.
Okay, so take a look at this case. There's 2 flare images. This is I think a diffusion weighted image. Tell me what you see on here. What structures are affected?
So, and the first one looks like bilateral mammillary bodies.
Right. This is the midbrain. These are your mammillary bodies over here. This is part of your hypothalamus in front of it, your tuberous cinereum. So the mammillary bodies are bright on flare. This is the third ventricle. What structures on each side of the third ventricle?
Where are you asking? The third ventricle, what is the question?
What gray matter structures are on each side of the third ventricle in this image here?
That's the thalamus.
Yeah, exactly. So mammillary bodies, thalami, and this is your midbrain. The aqueduct is here, this periaqueductal gray matter involvement too. So given this history of a guy that's malnourished, confusion, ataxia, ophthalmoplegia, what do you think this is and what deficiency is linked to this?
Wernicke's encephalopathy.
Right. And what's it from? What deficiency? So it's B1 or thiamine deficiency. And so for imaging wise, classically, they talk about involving four different structures like mammillary body, the hypothalamus in front of it, the thalami, and very commonly the periaqueductal gray. It's okay to have a little bit of bright signal around the ventricles, around the aqueduct, but when it's very confluent like this, then I start to worry about that. All right, so just more examples of the same thing. So they can be bright on flare and they can also restrict, like we're seeing in these 2 cases. This is kind of more examples of the same thing where we have like this flare image over here, like different flare images showing this bright signal in the thalami and periaqueductal gray matter. And this is an example from your in-service kind of showing the same thing. Thalamic bright signal bilaterally and like abnormal signal involved in the mammillary bodies. Okay. This is a companion case, Lisa. Just tell me what you see that's abnormal on here. So it's a person who's malnourished, also a chronic alcoholic with all this like edema and kind of like holes in their corpus callosum. Do you know the name of the deficiency that causes that?
Deficiency of.
It's a long Italian name.
No.
Anybody know?
It's Harvey something.
Benyami disease or something.
Yeah, exactly. So like different things can affect your corpus callosum. If you have a patient that's malnourished, alcoholic, and you see either edema or chronically holes in your corpus callosum, that's a good appearance for what's called Markia-Favre-Benyami disease. It tends to also involve the central fibers of the corpus callosum as opposed to the undersurface. So what structure is affected? This is the corpus callosum, and what deficiency is this from? This is just B vitamins in general are thought to be the cause of like deficiency of those vitamins are going to be the cause of Markia-Favre-Benyami disease. We talked about this already. I'm not going to get into that again. Just more examples of the same things. So acutely, it can cause diffuse edema and restrict. Chronically, you'll see holes in your corpus callosum that tend to involve the kind of like the central fibers. MS likes to involve more of the undersurface of the callosum interface. So there's some more examples of the same thing. Abnormal signal kind of involved in the splenium of the corpus callosum with restricted diffusion. And just to kind of go through this over here, let's see. I think I didn't put this slide together properly, but so if you look at this case, just to go over some like anatomy. So Lisa, what are these 2 structures over here? This is the frontal horns and lateral ventricles. What's indenting them over here?
That's the head of the caudate.
Yep. And what structure is this out here?
Where? I'm not sure what. I can't see where you're pointing. Next to it?
This thing, do you see my arrow?
This is just, yeah, but it's not pointing anywhere. It's like that side.
So this is the lentiform nucleus. The putamen's on the outside, the globus pallidus is going to be on the inside. What structure is this over here that we just talked about, like on either side of the third ventricle?
Your arrow is pointing outside of the brain, so I don't know where you're pointing. I can't see.
Oh, okay. So lentiform nucleus over here, putamen on the outside, globus pallidus on the inside. The white matter tract that's over here is going to be the internal capsule, and then between the third ventricle on either side of the third ventricle, you have like your thalami. So with that information in hand, if you have a case like this that has hypodensity kind of involving like your, this was actually shown in your in-service like within the past 2 years. If you see edema or infarction kind of involving globus pallidus, there's a differential for that. So like one thing they talk about is that carbon monoxide can give you this appearance. If you have methanol intoxication, and cyanide can also, all those things can involve your globus pallidus. And actually ecstasy or things that involve NMDA receptors can also involve your globus pallidus. So if you see like a case where you have edema or what looks like infarction involving your globus pallidus, these are the kind of things I would think about: carbon monoxide, cyanide, methanol, and lastly ecstasy. Silly picture, but let's see. See, Dr. Land.
Yeah, Dr. B.
Okay, so take a look. So you have your question stem over here: psychosis, Varizes sardonicus, like movement disorder. They have this abnormal kind of like ring when you look at their eye. And this is what you see when you look at their, this is a T1, really bright signal in the basal ganglia. And it's like kind of funny signal within their brain stem. So what do you think the best answer choice is for this?
Wilson.
Exactly, right. So in terms of like imaging, there's a differential. I've seen this actually kind of image shown on like your on your in-service a few different times with like the bright signal like on T1 within the basal ganglia. There's a long differential of like several things, but I mean it's probably worth remembering at least these for things that cause bright signal in your basal ganglia. So Wilson's is one. If you see that with the right history and like brainstem findings that look like a panda, like you're seeing over here, think of Wilson's. If you have cirrhosis, or if you're getting TPN from manganese deposition, then you can get increased signal in your basal ganglia. Gadolinium, if you do repeated like MRIs with gadolinium, it can deposit like the basal ganglia and also in the cerebellum. They also say NF can sometimes give you funny signal on T2, but also on T1 that can involve your basal ganglia. So this is what's called like the panda sign for Wilson's disease, like when you see it within the brainstem, and you can also see the bright T1 signal in the basal ganglia from manganese deposition. So this is kind of like just more of the same thing. This is like non-specific. What you're seeing is bright signal in the basal ganglia, even like the ventral thalami. If you see high T1 signal in the basal ganglia and that abnormal appearance of like the brainstem with the bright signal kind of like the midbrain, then I think of Wilson's with the right history. So just another example showing bright signal within the basal ganglia. And this is that abnormal appearance of like the brainstem. So this was shown, I think, a couple of years ago. There's some bright signal in the basal ganglia on here. I'm not sure what the answer is, but in terms of a differential, these are the things I would think about for like bright signal in the basal ganglia that's symmetric and kind of uniform looking. So cirrhosis and TPN from manganese deposition, Wilson's disease. Methanol can also involve your basal ganglia too and give bright T1 signal, GATO deposition, NF, and calcifications. Another example of the same thing, I'm not sure the diagnosis here, but if you look, there's bright signal in the basal ganglia on both sides. I would think of this same differential if you see that, then narrow it down based on the question stem. Dr. Land, this is another metabolic disease kind of involved in the basal ganglia bilaterally, causing dense calcifications that are also within the cerebellum. There's a differential for this, but what do you want to think of on a test if you see this?
I'm gonna say it looks like Fahr disease.
Yeah, exactly. So in terms of a differential, after 30, you get calcium and iron deposition in your basal ganglia. If it's a young patient and they have faint basal ganglia calcifications like a child, I'd wonder if they have HIV exposure. Different metabolic issues can also give you calcium and iron deposition in your basal ganglia. Fahr is a big one to think about if you see this appearance on a test. And there's a pediatric disease called Cockayne syndrome that can look like this too. I think if they're showing this on a test, what they're probably looking for is Fahr's disease. Let's see. So we talked about some tumors and like including some slides on like the ones that were on your in-service. I talked about hemorrhages in different spaces. I talked about a few different infections. I talked about a couple metabolic things. Now I'm going to actually talk about a few different degenerative dementia examples. So let's see. Jihan?
Yeah. Huntington disease seems most likely.
What's that?
Huntington disease.
Right. So just tell me what's abnormal here.
So there's I think the caudate is atrophy and there's enlargement of the frontal horns bilaterally.
Right. So your frontal horn should be kind of comma shaped with the caudate head indenting it. If you look over here, the caudate's kind of small. The frontal horn is more box shaped and not comma shaped. It's a young person, so they have that plus generalized brain atrophy. So with caudate volume loss, lots of brain atrophy and like these other symptoms, movement disorder and like psychosis with a family history of this, I think Huntington's would be the best answer. So this is normal, especially in a young person. Caudate heads indent the frontal horns and give it like a comma shape. When you see atrophy of the caudate heads and you see kind of a ballooned out box shaped appearance of the frontal horns and not comma shaped, I would think of caudate volume loss, and if it's bilateral, I'd worry about Huntington's disease. Autosomal dominant, it has that anticipation component to it in terms of it like getting worse with these like generation people having it like at like a younger age. So that's pretty much the imaging appearance of this, like with the caudate head atrophy. There's different metrics they can use and like ratios to kind of measure like a caudate volume loss, which I'm not going to get into, but this is just more examples of the same thing. The frontal horn should really be comma shaped, indented by the caudate. If you see it with a boxed out appearance, worry about this disease with the right clinical history. And I think this is an example of Huntington's from your in-service where it showed this kind of ballooned out like frontal horns and kind of small caudates. Let's see. So Jihan, just take this case and take a look at it and tell me where you see the atrophy. Actually, this is probably a better example.
So, I'm not so sure, but Zhang by my side is saying is frontotemporal dementia, and there's significant atrophy of the hippocampus and also enlarged ventricle compared to the. So I guess like frontotemporal part is more atrophy than the occipital.
Right. So there's generalized brain atrophy, especially hippocampal volume loss. The ventricles are big, but I think this is not hydrocephalus because if you look at this case, the sulci are pretty big too. The callosal angle is not acute. There's no effacement of the sulci up here. So this looks more like an atrophy picture than a hydrocephalus picture. The thing I was trying to get you to lean towards, because this is mostly like temporal, actually, like temporal and parietal is actually like Alzheimer's for this one. So dementia, preserved motor function, no abnormal gait to go along with hydrocephalus. I think actually the best answer for this, I mean, it's a toss-up between like frontotemporal dementia and Alzheimer's, but I think this is a better look for actually Alzheimer's disease. Everyone, I mean, you guys know the pathophys for this better than I do about like amyloid deposition and neurofibrillary tangles. For imaging, the stuff you're going to be looking at is like mainly temporal and parietal cortical atrophy and volume loss involving your hippocampi, which you can actually like grade on a different scale. So this is kind of like a normal appearance over here, and then like you can see like especially over time, like you can get more and more hippocampal volume loss for this disease. So the way you kind of like grade this is by looking at like how small the hippocampi are and how big the temporal horn, the choroidal fissure is. All right. Jihan, keep going. I just want you to take a couple more of these degenerative dementia cases. I only have a couple of minutes left. So it's a patient with dementia that's stepwise. And if you look on here, there's encephalomalacia here, encephalomalacia here, and lots of white matter changes. So what do you think this is?
Just vascular dementia, I suppose.
Right. So, I mean, I would think of this if you see lots of white matter changes, which there's a Physicus scoring system for it in terms of mild, moderate, and severe, depending on if they're punctate or if they're like more than just a few, or if they're very confluent. If you see lots of white matter like changes that you're seeing over here, they're more than say 25%. If you see infarcts, multiple infarcts, especially when they're in strategic places, I would think of vascular dementia, especially if the dementia is like kind of stepwise. So they talk about like infarcts in specific locations. I mean, if you have thalamic infarcts, the ventral thalamus, I think, is involved with cognition. If you have bilateral ventral thalamic infarcts, that can kind of lead to this diagnosis, among other things. Just going to go through this quick. And this is that Physicus scoring system that I was talking about before. When I see white matter disease, I tend to try to say if it's mild, moderate, or severe. The more of this you have, the more risk you have of developing vascular dementia. So Jihan, so take a look at this case. This is a younger person that has white matter changes, a family history of strokes at a young age. And if you look at their anterior temporal lobes, there's some bright signal here. So what do you think this is?
I think it's CADASIL.
Right. I mean, demyelination is another possibility for this patient. That also likes to go to the anterior temporal region, in addition to the other areas that MS and things like that like to involve. To give a younger person with the right history and anterior temporal lobe involvement, like you're seeing over here, that's a good appearance for CADASIL. This is a really expensive test that I think is a send out of Kings County that probably doesn't come back after the patient's discharged, but you can check for the mutation of the Notch3 gene of chromosome 19. There's a test for this. They're just like examples of what to look for. So white matter changes in like the young person, what looks like lacunar infarcts. And again, the anterior temporal lobe involvement is like kind of like a big thing that they talk about. Small vessel disease, unless it's extensive, tends to kind of spare the anterior temporal lobes. However, CADASIL and MS like to go to those places. And this is an example from your in-service showing abnormal white matter signal in like a younger person involving the internal capsules and also the anterior temporal lobe. So this is an example of CADASIL. This is kind of like what you were talking about before. Lots of brain atrophy, especially involving like the anterior temporal lobes and the frontal lobes. That's really rapidly progressive over a couple of years with these knife-like gyri. So this is an example of frontotemporal lobar dementia. And this is an example from your prior in-service, which I think is showing frontotemporal dementia more than something like Alzheimer's. There's huge kind of like sulci, like knife-like gyri bifrontally and lots of temporal lobe volume loss. So this is a good look for frontotemporal dementia over, say, something like Alzheimer's. I'm gonna just go quickly, or for like 5 minutes more, just to go over a couple more things, and then I'm gonna stop. Because I think one or two of the things I'm going to talk about were actually under in-service in the past. So Lewy body dementia, I feel like there's a big clinical component to diagnosing this, and you can also use PET to diagnose Lewy body dementia. It causes a number of different clinical findings, including visual hallucinations. Because of that, if you do a PET scan on someone that has Lewy body dementia, you'll see occipital lobe hypermetabolism. That's typically what you're going to be looking for if you're able to get a PET scan on these patients. So occipital lobe hypermetabolism is what you're going to be looking for these people. Let's see. I have to go quickly here because I'm kind of like past my time limit. Dr. Land?
Yes, Dr. V.
Okay, so I'm going to go through the last couple of cases. I want you to just tell me what you see. So this is a person with a Parkinson plus syndrome. So if you look at their brainstem, like on the sagittal T1 and on the axial T2, what do you see on here?
So basically, first of all, you see on the sagittal, you see like a significant atrophy of the cerebellum, and then on the axial, you see like the hot bound or holy cross sign on the brainstem. So I think that's his MSA.
Okay, how about the pons? Is that normal, or is it their volume loss there too?
Pontine, yeah, there's a lot of.
Yeah, it's kind of flat actually. So cerebellar and pontine volume loss with that hot cross bun sign. This is kind of a classic appearance for multiple system atrophy. I'm just gonna go through this quickly because I'm out of time. So pontine volume loss, that cruciform appearance within like the within the pons, and cerebellar atrophy, like we're seeing over here, I would think of this specific entity. So this is normal. The interfolial spaces should be less than like say 1 or 2 millimeters. They're markedly widened here. The fourth ventricle is big because the cerebellum is atrophied, and you're seeing the hot cross bun sign. So this is an example of MSA, and this is an example from your in-service. So cerebellar and pontine volume loss and the hot cross bun sign, I would think of MSA. I think spinocerebellar ataxia can also give you a similar appearance, but their cord will be small. Another person with a Parkinson plus syndrome. So supranuclear gaze palsy, postural instability, and dementia. Dr. Len, what do you think this is?
The CT chest just to rule out
Progressive supranuclear palsy.
Right. This is a normal Sag T1. The top of the, this is your midbrain, tectum tegmentum. The top of the tegmentum should be nice and round. If it's kind of like caved in or volume lossy, like you're seeing over here, I would think of this specific process. So this is our case. See at the top of the tegmentum is kind of like caved in. So this is called like the hummingbird sign or the penguin sign. That's what I would look for this. So the Sag T1 or T2, like you're seeing in this case, is the money shot. This is supposed to be around if it's caved in, then I think of PSP. Corticobasilar degeneration is like another thing they talk about for Parkinson plus syndromes. The big thing I would think about for this, besides the clinical features, are if you have a brain MRI that shows atrophy that's more on one side than the other, like in this case, that suggests the diagnosis of this besides your other ancillary findings. I'm going to stop there because like the rest of this is just talking about PET and like I'm kind of out of time. If you guys, good luck on your in-service. I think it's coming up like next week. If you have any questions, just shoot me an email. Thanks.
Thank you, Dr. V.
Thanks, Dr. Vin.